Hi, everyone. Welcome to the conference. My name is Rachel Johnson Yates. I am the Deputy Director and Chief of Staff for the Division of Mental Health and Addiction, and we are so glad to have you here today. Next slide, please. And so as I talk today, where I will be starting is just kind of to set the tone for the conference. We are all here as people that are working in the social service realm that serve a very diverse population, and we're all here because we are incredibly passionate about the vision of the Family and Social Services Administration, which is to compassionately serve our diverse community of Hoosiers by dismantling longstanding persistent inequity through deliberate human services improvement. Next slide. And so the division, for those of you that may not be familiar, the Division of Mental Health and Addiction is under the umbrella of the Family and Social Services Administration. And about a year ago, we took some time to really kind of retailer our vision and our mission. And today I wanted to share that with you. For those of you that work in the mental health, substance use disorder prevention, suicide prevention, crisis realms, the work of DMHA has been recently transformed to be very, very focused on the people that we serve. And so we very intentionally use the words an unyielding focus on promoting and supporting the mental health and wellness of the people of Indiana. And that word unyielding is very, very important, because if we, as we are doing our work, are focused wholeheartedly on the people that we serve, the human beings whose lives we hope to make better through how we've dedicated our life and our careers and all of the work that we do, the rest of it is ancillary, and we're able to stay focused on what things are good and right and true. And so again, our vision is to have an unyielding focus on promoting and supporting the mental health and wellness of the people of Indiana. And our mission is to champion mental health promotion, substance use disorder prevention, treatment, and recovery services that are high quality, seamlessly integrated, and accessible to the people and communities of Indiana. Next slide. So what is important to remember about this? So we break down these three categories a little bit: the high quality, seamlessly integrated, and accessible, to kind of give some operational definitions of what it is that we are hoping to do through all of the work that we do through providers like you that are on the call today. So under the umbrella of being high quality, we are aiming for services that are, number one, person-centered, innovative, data-driven, evidence-based, peer-driven, culturally competent, and trauma-informed. And what is really important to remember about each of these things as we think about cultural and linguistic competency is the idea that if we are going to be responsive to the myriad of cultures and identities and individuals that are in front of us, we have to look at the person. There is not cookie cutter treatment for an individual. We have to be innovative, because treatment is not a one size fits all sort of approach. We have to use data and evidence to determine, is what we think we're doing actually what's happening in the client practitioner relationship. Peer driven is very, very important, and Dr. Carey will be talking about a little bit later what it means, some of our work that we have done to have our peer force be more representative of the populations that we're serving. And then culturally competent. And I want to talk about this idea of being both culturally competent and culturally humble. And so when we approach our work with cultural competency, that means that we are really, really taking effort to make sure that we are well educated and well versed in the needs of the various populations that we serve. When we talk about being culturally humble, we understand that there is no way that any one person can have a full picture of all of the nuance of every sort of way that a person might connect with their various cultural and identity components. And so being culturally humble means we, again, are person-centered and let the individual in front of us drive the direction of their treatment and their engagement in the social services that we have. Seamlessly integrated means that we have a full continuum of care. We have strong partnerships with all kinds of organizations that are able to support the recovery and the prevention of for the people that we serve. We have smooth referral processes, minimize silos. We function with our payer sources, and that we include shared populations, meaning people that maybe have a mental health issue and a disability are able to be served in a manner that addresses both of that individual's needs. And in terms of being accessible, it means that we are reducing administrative burden, that our services are accessible to both clients and providers, and they're easy to use, expedient, transparent, and that the access to care is also expedient. And so as we're looking at this, there's still a lot of room for improvement. These are our aspirational goals, and these are what we are working toward moving toward every single day. And as you think about this, cultural competency, cultural responsiveness is really the undercurrent that is at the core of making all of these things function in the way that we want them to. Next slide. So I want to talk a little bit about disparities in mental health, and I'm only going to give you a few bullet points today, and you will get a lot more very valuable information as you go through this conference. But a couple of disparities in mental health that I want you to just kind of take away as food for thought as you go into the rest of the day and the rest of the day tomorrow. Think about what sorts of things may be happening that are perpetuating the issues that are on the screen right now. And just so that we can start kind of thinking about this, some of the disparities that specifically impact the population served by the Division of Mental Health and Addiction. African Americans with an affective disorder, so something like an anxiety or depression or other mood disorders, are more likely to be diagnosed with schizophrenia than are white patients. And why that is a problem is because schizophrenia tends to be a disorder that we think is much more difficult to manage, that recovery looks much more different, and a lot of times the resources and the treatment approaches that are indicated for schizophrenia are very different than what is effective for a mood disorder. And so this misdiagnosis has really critical impacts on the way that individuals are served. People who are African American and Hispanic are less likely than the white population to receive guideline-based care for depression and anxiety. For those of us that are familiar with guideline-based care is rooted in evidence and research and efficacy that it has been demonstrated to be effective. If we are not promoting treatment services for every population that needs it that are guideline-based, we are doing an incredible disservice to these individuals in terms of their opportunity for recovery and being able to lead a life that is healthy and successful by their definition. Around 10% of people who don't speak English receive the mental health care that they need. And so the flip of that I want to make sure to illustrate is that 90% of individuals in our country who don't speak English that need mental health services are accessing it. 90% are not accessing that care that they need. Only 10% are. And that is a huge disparity and a huge need in our community. People who live in rural areas have less access to mental health services than do their more urban counterparts. So as we talk about cultural and linguistic competency, it's really important to understand the nuance between the different populations that we serve within the programs that we lead, and understanding that the nuance can be understood on a community level as well as an individual level. Next slide. So here I'm going to ask you to think about where do you have control and influence? And the purpose of this slide is really to help us understand that for those of us that are very passionate about equity, diversity, inclusion, belonging, all of the needs around these issues can be seen as can feel really overwhelming. And we have seen since 2020, after the George Floyd murder, after the social justice movement and uprising, that there have been a lot of areas where the work around diversity, equity, inclusion, and belonging has stalled, and where people have reported, gosh, it feels like this was really important a year ago and now we've forgotten about it. And part of the reason that can happen is because doing this work can feel really overwhelming. So I want to kind of break down our approach. The outside circle is this idea of things that concern us, but that we may not have control over. So this could be things like the weather, politics, natural disasters, actions of others, those sorts of things that may impact us loosely, that we worry about, that can feel overwhelming, but that ultimately we don't have a lot of control over. The next circle in is around what do we have influence over? And most often this is our community. So community can be defined in a lot of ways. In this instance, typically we define it as the people in your life, your family, your children, your neighbors, and your coworkers. So when you think about who you can influence, this in terms of cultural and linguistic competency starts to play out around what sorts of conversations are you having? When you hear someone say something that is maybe problematic, what do you do to call them in and maybe work with them to develop a different perspective? How do we help people in our lives understand when they are using language that maybe perpetuates disparities or perpetuates misunderstanding or perpetuates hate or perpetuates all of these other issues? We actually have a lot of influence over our community, and we have to think about how do we use that influence to help move the needle on diversity, equity, inclusion, and belonging. And then what do I have control over? And so for each of us, this is going to look a little bit different. If you are in a position where you have some leadership responsibilities, you might have a bigger footprint of control. But every single one of us has a level of control in the work that we do, the spaces that we occupy, the conversations that we have. And this is really where it is important to start to focus our work in the area of improving diversity, equity, inclusion, and belonging, is making sure that we're starting with what we can control, that we're growing in that area, and that we are remaining focused there and trying to do our best to enhance our skill set in that manner. You don't have to do things perfectly every time, but as long as you're thinking about it, working on it, talking with people about how we can do things better, that is a step in the right direction. Next slide, please. So I'm going to use this quote. I love this quote because I think one of the reasons that inequities persist and disparities persist in our community is because oftentimes we are socialized to prioritize keeping the peace rather than speaking up. And there are ways to speak up that can call people in and help educate things and help make changes in incremental manner that don't have to be necessarily the approach of causing a lot of conflict or maybe all of the things that play in our head when we get anxious about speaking up. And so today I want to encourage folks that as we go through the day, as we learn more, as you learn things, understand that you're not the only person learning, and that the information that you take in today will bring back to your agencies, bring back to your leadership, reach out to us about ideas that you have. And it's very, very important to figure out how to speak up and how to use your voice in a way that works for you to help increase equity across the board for the people that we serve and the people in our lives and our communities. And so this quote says, "We can learn to work and speak when we are afraid, in the same way we have learned to work and speak when we are tired. For we have been socialized to respect fear more than our own needs for language and definition. And while we wait in silence for that final luxury of fearlessness, the weight of the silence will choke us. The fact that we are here and that I speak these words is an attempt to break this silence and to bridge some of those differences between us. For it is not difference which immobilizes us, but silence. And there are so many silences to be broken." And so as you go through this day, think about in your life and your work and in the areas that you have influence and the areas that you can control, where have you maybe been silent and why? And what do you need to be able to speak up, to advocate, and to make the world around you a better place for the people in our community, for our families, for our friends. Next slide, please. And as we begin, I would like to encourage you today to, number one, just speak from your experience. Our experience is our main point of reference, and it's really important to start there and to understand that your experience is an excellent lens from which you can start and which you can build upon. Use the language that you have, ask questions. If something doesn't make sense to you, ask for clarification. Next, understand that we are both individuals and parts of systems. And so I may be a person that is very, very dedicated and committed to the ideas of diversity, equity, inclusion, and belonging. And I also may be parts of systems that perpetuate inequities and disparities. And it's important that we figure out how to integrate our identity as individuals and our identities as individuals in parts of systems to figure out how to improve all of the areas that we touch. Try your best to be present. Conferences are very distracting. There's a million things going on. You've got your emails coming in, you've got people calling you, you've got a lot going on. As much as you can, try to dedicate your presence to the conference as it goes on today, so that you can be fully present, take in what you need to in order to make change in your community. Expect a range of emotions. The things that we're going to be talking about are tough. The things that we'll be talking about need us to self-reflect, to figure out what we have done to maybe perpetuate some problems, what we need to do differently to help disrupt these systems of oppression that have led to disparities over the years. And sometimes that's hard to do. And so expect a range of emotions and understand if you're feeling a range of emotions, that's okay. And that means that you're actually connecting and doing the work. It's very important to have a colleague, a friend, somebody that you can talk to if there's some emotions that hang on for a while afterwards, so that you can figure out what to do with them in order to move forward in a productive way. Take a seat at the table. This is really important in terms of creating change, challenging thought processes and beliefs that maybe we have that are no longer true, and really starting to take an in-depth understanding of the work that we need to do and how we might be able to do it in the most effective manner. And then lastly, I am so happy that we are here. You all had the opportunity to do about a million other things today. You've been, again, pulled in a lot of directions, but you are here and you're choosing to sign up and step up to learn how to make our community better for everyone whose lives are impacted by the work that we do. And thank you for making that choice. Thank you for being here, and thank you for being dedicated to this work. And so now I'm going to kick it over to our Executive Director of Equity and Systemic Integration, Dr. Corey Carey, who's going to talk a little bit more about the work that we are doing within FSSA and the Division of Mental Health and Addiction. Thank you.
Thank you, Rachel. Good morning, everybody. I first want to just give a huge thank you to everybody who's on the conference today for the challenging and I think often under-acknowledged work that you all are doing for the Hoosier population. So a big thank you to everybody. As Rachel said, I am DMHA's Executive Director of Equity and Systemic Integration. And I wanted to just highlight that my role within DMHA is a new role, and it was developed with the mission and the vision of DMHA in mind. The purpose of my role is kind of is an expression in some ways of the need for cultural and linguistic competency throughout the work that we do. So with a career as a psychologist and some experience myself in expertise in culturally competent care, I'm humbled, but also impassioned by the work that we have ahead of us. My entire career prior to DMHA has been in clinical care and direct service. And so I understand the significance of the work that we do and the needs of our clients and our systems. So what I'm going to do is to talk to you a little bit more about how DMHA has transformed our structure and our approach to service delivery so that we can kind of maintain our commitment to our express vision and mission. You can advance the slide. Thank you. So as kind of Rachel mentioned, we've in the past had some kind of silos or bureaus that have existed in our system. And so there's been a concentrated effort within the current DMHA administration to move out of those boroughs, out in the silos that have developed over time. You know, as many of you know, as federal funding guidelines will have it, mental health, substance use are often approached separately, especially with regard to funding, service delivery, with data, with policy. However, as you all know, mental health and substance misuse overlap quite a bit, right? And so we don't want to think about mental health and addiction necessarily as kind of these two buckets that exist, although we often have to approach things that way. So as public servants, you know, we have a responsibility to administer our services to people in a way that promotes equitable access. And so we want to be kind of sensitive to the reality that mental health and substance misuse often overlap, right? And how they play out in the people that we work with. But we don't want to forget kind of the full picture, and we don't want to neglect the reality that wellness is much more multifaceted than these kind of two buckets. Next slide, Sunny. So what you see here is a graphic, so to speak, of what we would kind of like for you all to kind of envision our system currently. And so instead of looking at just mental health or substance misuse, we want to recognize that prevention of substance misuse and prevention of mental illness is incredibly important, as well as kind of the other side of it, that when folks struggle with mental illness and substance misuse, they don't necessarily have to stay in that space, right? So we have robust recovery support initiatives going on within DMHA as well, recognizing the importance of peers and folks with lived experience, right, to kind of help folks in recovery and help kind of push forward the mission of DMHA. And so, as you can see, kind of there's an arrow that goes across the bottom that suggests that equity goes across all of these systems, if you will. And that is kind of how we want to start to approach things, right? The other piece that I didn't include on this slide, but also I think is important to note, is data and the extent to which we're data driven in the work that we do. That also would cut across. So it's our mission to champion prevention, mental health promotion, and substance use and treatment and recovery services in a way that's integrated seamlessly and that's accessible. And that word accessibility and services being accessible is phrasing that you'll hear quite repeatedly. Because if we're taking a culturally responsive approach to addressing mental health and substance use, then we have to examine the health disparities of our populations, right? We have to consider social determinants of health and the various aspects of a person's well-being that kind of play a role. And so that might mean housing, education, their economic stability, their physical and mental health, of course, as well as community and community supports. And so at DMHA, we're interested in minimizing the disparities by providing equitable access and equitable service provision, as well as pursuing equitable outcomes for the folks who utilize our services. And so this applies to some of our underserved populations, folks who might be involved in the justice system, who don't get, always get equitable access to services, as well as our consumers who are BIPOC, our consumers in rural communities, our consumers with disabilities, and across the lifespan as well, from our young consumers all the way up to our older adults, right? The other thing that I'll mention is our current structure has it so that we have teams of folks and very significant initiatives with federal funding that touch on and cover prevention work, right? And that's currently led by Dr. Christopher Poe. And we have a mental health team led by Sorella Blackman, addiction team or a substance misuse and a team that's led currently by Rebecca Buhner. And then we have a sort of well-rounded team of folks who are leading off our recovery services. We have a couple of new positions or new folks who filled positions leading our recovery support work that was formerly led by Amy Brinkley. So we're very excited, about kind of the hard work that's ahead of us and the teams of folks who are involved in advancing our work. So I want to take a second just to kind of highlight a few of the projects that we have going on within DMHA so far. So we have received an influx of federal funding over the last year or so, and our teams are hard at work at advancing some initiatives. And a few that I want to highlight that are related to equity and equitable access are some of the ones you see here on the screen. So the first that I'll talk about is our BIPOC peer expansion project, which really is an effort to increase BIPOC representation in a certified peer recovery profession. We've partnered with some folks from who are in sort of the workforce arena, if you will, to target populations of individuals who might be justice involved, for instance, who might have lived experience, and who might have sort of a breadth of knowledge and experience to become certified as peers and work in the field. That project is kind of up and going, and we're looking forward to seeing kind of the outcomes there. The ultimate goal is to increase the number of individuals who are BIPOC peers. One of our other projects, a huge project actually, is our federal class standards assessment, which is a project that is taking place in conjunction with the Indiana Council of Community Mental Health Centers, in partnership with the Race and Equity Leadership Team there. So this project is an effort to establish a baseline and implement recommendations on workplace culture, as well as service provision. And so this is going to happen through a comprehensive assessment across all CMHCs that results in a set of recommendations, as well as an implementation plan. And I know I'm saying kind of a lot of words, but I can't stress just how significant this project is going to be. We are kind of currently in the RFP stages of things. And like I said, working pretty closely with the council because there is a recognition that we want to kind of revamp and strengthen our CMHC systems and make sure that we are providing the best and the most equitable service, not just in our delivery, but also in the way that our providers are trained and knowledgeable. Another one of our funding projects right now is the Accelerator Program. And so this is going to be an effort to increase the capacity of some of our grassroots organizations who might not always have the access or resources to provide the services that they like. And so this is going to allow for some technical assistance and really a way to improve mental health and substance use disorder outcomes through increasing kind of a responsive and more representative workforce. And then finally, not a final project, but sort of a final project spotlight, we have an RFF out for a low barrier shelter grant program. And this project is to increase, an effort to increase quality, integration, and access to our shelter services that provide mental health and substance use disorder treatment and recovery for folks who are unhoused. The state is specifically interested in these funding low barrier shelters and associated programming through either site construction, residential services, case management, staff development, really kind of integrating housing and the need for housing with treatment. And so one thing you may have noticed as I kind of talked through some of these projects is sort of the mention of workforce, right? And an effort to increase workforce. And one thing that I didn't yet mention about my role is that I also kind of work closely with our executive team and with the DMHA to address our workforce issues. It's not lost on DMHA or the state of Indiana's executive leadership that we have a workforce crisis. And this, of course, is inclusive of behavioral health workforce. And so we hope that you'll recognize that a lot of our projects are going to be geared toward addressing that need, either directly or indirectly. That being said, I think this makes your presence and your commitment to our consumers even more valuable and significant because you're out there kind of doing the work and you're so appreciated for it. With that, I want to wrap up and I want to go ahead and introduce to you our next speaker, who I also have the benefit of working pretty closely with in the work that I do at the state, Dr. Brianka Merritt, who is the Chief Equity Officer for the FSSA. So Dr. Merritt, I'm going to go ahead and hand it over to you.
Awesome. Thank you so much, Dr. Carey, and to Rachel for your overview. Like Dr. Carey said, I'm here to talk a little bit about how everything she and Rachel discussed really fits into the larger scope of what we're trying to pursue for FSSA. Next slide, please. So Rachel already shared this, but I think, again, it really grounds a lot of our discussion and the work that you'll be doing over the next couple of days to reiterate what FSSA's mission is as it relates to everything, including the role of inequity. And as you can see, we have the role of dismantling longstanding and persistent inequity as a key, is the mission of our agency. And that's critical because it identifies and really centers the idea that inequities are rooted in policies and program design. And so when we talk about the fact that these things exist through human services themselves, we're acknowledging that we are part of the problem, and so that therefore we need to be part of the solution. And so by being able to say that and state that, it gives us a lot more leverage compared to a lot of other agencies and other organizations to really have that that foundation to build off of and justify even more the importance of integrating things like equity throughout what we do. Next slide, please. So I talked last time, a year ago, a little bit about what our office does, who we are, what we do. And so just as a recap for folks who might not know, in my role, I oversee and direct our Office of Healthy Opportunities, also known as OHO. And our office was created to address social determinants of health, social risk factors, social drivers of health, whatever term suits your fancy, that addresses Hoosiers' quality of life. So Dr. Carey talked a little bit about this. We can think about them in a lot of different ways, demographic, economic, social, geographic, et cetera. All these different factors that influence how we live. To the right, you can see a graphic that we use that highlights some of those key things. And again, Dr. Carey mentioned these: employment, food access, education, transportation. We definitely consider not just mental health, but access to mental health services as a risk factor as well. And so collectively, this office was created a few years ago to do that. And so my position was created to help support and really kind of drive what we actually do around social determinants of health. So our key driving tagline is that we identify risk factors and address them. And so collectively, our goal, as it implies there, is that we're not just serving our staff, we're serving our constituents, we're serving Hoosiers across the board, across these different issues that want to, that affect their ability to live with a high quality of health and well-being, and also enabling and supporting our staff to do that. So I'll talk a little bit on the next slide about what that means for us. So what are our goals and vision? To the right, you can see a graphic that I think really highlights our process for how we engage and really try to center, or trying to center lived experience in what we do. And so our first prong is really around community engagement and the fact that we know that we need to be working with our community partners like yourselves, as well as with folks who are constituents who access our services, who are Medicaid members, who are customers of our vocational rehabilitation services, et cetera. Because those are folks who frankly know how our programs work, sometimes even better than we do, because they can tell you what's working, what's not, and what you need to fix. So by being able to engage more deeply with the community, broadly speaking, we hope that that will lead to policy and program design and redesign. So again, getting that feedback up front will help us better identify what are some gaps, what are some opportunities for improvement, and what things are working well that we can build off of to then create systems that are more equitable for the folks that we serve. So a critical component of this redesign process is skill building and knowledge sharing among our staff at FSSA. So with that, that means that we are not just providing a myriad of trainings to folks around issues of equity, social determinants of health, but really understanding and hearing from them what are things that might make their experiences within the agency better, what are things that they're seeing on the ground, and how can they create spaces to then share that with other folks to build their knowledge base again and share what they have learned from working directly with constituents and in doing their jobs. And then as a result of all of those things, we hope that we can gain more evidence, more data, and structures and systems to hold ourselves accountable, not just in terms of meeting specific benchmarks, but what that means with regard to actually supporting our leadership, supporting our staff, and making sure that we're not just looking at numbers, but we're actually being able to tell a clear story, and a story that allows us to be able to say, here's what you may or may not be doing well, and here's how we can work together to move that forward. And so based on that evidence, that research, that systems building, we can then go back to the community and engage them on what we are doing as a result of what they've shared. So that's our general perspective here. It's kind of broken out into 4 key goals. And I think based off of what Dr. Carey and Rachel have already shared with you, you can see maybe some of what they've shared. I'll talk about that a little bit more, and some of the work they're doing in DMHA that fits very nicely into these key goals. The first, which I alluded to, is around ability to co-design programs and policy with those to say constituents, meaning that we're not just letting people have a seat at the table, we're making sure that we are actively engaging them in processes and ensuring that what they are doing, if they are, we don't want to be in situations where we're forcing people to relive their trauma with us and then not follow up, not do what we're supposed to with regard to making tweaks and letting them know and having them serve as advocates and supporting them as well. So that co-design process is really key, because that's a step further than just kind of listening. It's saying that you're a key part of moving this work forward. Secondly, that we have accessible and effective programs that equitably serve Hoosiers. Third, that we have a representative workforce that's knowledgeable about social risk factors and how to address them. And then lastly, that we have high quality accountability mechanisms for equity guided by research and evidence. And so I think Rachel and Dr. Carey talking about the work of DMHA, their work with community engagement, their work with really restructuring some of the programs and thinking about workforce design, in addition to their great quality improvement team, all those things really fit nicely into the goals and vision that we have for our office and for the agency as a whole. Next slide, please. So I won't go into these in a lot of detail, but I talked about how our office is tasked with identifying risk factors and addressing them. So with regard to identifying risk factors, again, these are in the four main buckets I've shared before. So here's some activities that we are currently doing or planning to really help identify these risk factors even more effectively. Under the community engagement bucket, we are doing some work in identifying gaps in services, working with some of our internal partners who do community engagement work around building spaces for folks to share their perspectives, for us to get feedback and to integrate that more effectively. So getting input on program design and implementation so that we can then build some better systems. There are some folks, again, in DMHA, including their BIPOC initiative and outreach group that does some of that work already with providers, and some of you might be a part of that. So that's just a taste of what we hope to build on for the entire agency. With policy and program design, we're doing work around analyzing and utilizing a tool that we've built to identify and score gaps in equity with programs and legislative decisions. We've been working well with Dr. Christopher Poe and the 988 team around suicide prevention to get a sense of what some gaps might be as they roll out their programming, and supporting them as they, again, kind of also do community engagement to identify certain communities around suicide prevention and what we can do to support. With skill building and knowledge sharing, we're doing work now around listening sessions with staff all across the agency to get a sense of, especially with regard to programming, what could be different, what could be better, what can we do to support as an agency, and what can we do to support those providers, organizations, and individuals we serve. That also helps us identify gaps in program design for some of the folks we serve. And then lastly, we've been doing a lot of work around digging into gaps in data collection, management, identifying different target populations and analyzing data that we have, as well as working with evaluation, building out an evaluation process for our external partners to help us identify, again, externally, what do these things look like so that we can better tweak, have more evidence to support some of the work that we're all trying to do in this space. Next slide, please. So I talked about identifying risk factors and figuring out what the lay of the landscape looks like. And so, of course, the key thing here is addressing risk factors after that. One thing that we're building out is something called a social risk factors task force, which would actually consist of different entities across the state, primarily focused on state government, to understand policy change and what we can do. We have lots of community partners who are out there beating the drum for different communities and populations about what's needed for their health and well-being. And then the bottleneck happens with us at the state. And so how do we better, either revisit existing programs or think about what kind of areas we can actually have control over breaking up, so that we can have a more systemic and holistic approach to support our community organizations who are doing the work on the ground. We're also doing work around compliance and goals around social determinants and health equity needs and community engagement as well, so that we can, again, kind of build systems, not just internally, but externally too, and support those who are already doing the work. With policy and program design, we're going to start a training program toward the middle and end of this year with each of our divisions across the FSSA to train them on how to use those assessment tools and giving them some ability to then kind of identify their own equity gaps and hopefully again kind of build that knowledge for them so that as they're designing and redesigning existing efforts that they have that in mind. We also have a map of all of our programs, which we have not previously had, so that folks can kind of easily identify potential collaborations and updates so that they can, our staff can also learn from each other in that sense. Related to that, we're working with different staff across the agency to build out participation educational campaigns so that folks can be incentivized to learn, build their knowledge base around social determinants, around health equity, and also building out these things called employee resource groups, which are very common in other spaces, but not so much in state government, so that folks have like-minded folks to kind of learn from and grow. Some things, for example, our first one is called No Barriers, which is a focus on folks with lived experience and expertise in disability. We're also getting some feedback about folks who want to start something for our administrative staff across the agency, people who want to do one for young professionals, working parents, et cetera. So people can understand kind of not just different populations and communities, but other things that can help build out their experiences. And lastly, we're conducting some equity audits around our data, understanding better what our staff look like, which has not been done really consistently across the state in the past. That includes things like an inclusion survey, building out a reporting system for our staff to kind of provide feedback about what they're experiencing, and also some vendor and partner tracking to have a better sense of who we're collaborating with, who serve and support communities of color. Next slide. So I talked a little bit about how we address all those things, or what we're doing to identify and address risk factors and how those fit into our different goals. And so I did want to give an update about how we're actually doing this. So the last time I spoke with this group, we only had a few of those boxes at the bottom of the screen. I'm really pleased to note that it's moved beyond me and volunteers across the agency, but really a cross-collaborative effort to really think through how we meaningfully address social determinants and health equity. You can see at the bottom, those folks are really kind of undergirding our work here at the state and FSSA by helping us think through bringing their expertise around disability, racial equity, social equity, education policy, and a number of other topics so that we can be creative and thoughtful, and also bring in different folks from across the agency to give us their expertise and knowledge about what they think could work best, not just for our staff, but also for our constituents, of course. In my team, we have in our building out, we currently have hired an ADA coordinator who is dedicated to the experiences of those with disability, both internally and externally to the agency. So frequently getting constituent feedback and building out spaces to collect that more readily. We are in the process of hiring a community engagement specialist and a director of social drivers of health, and collectively they will both kind of be in charge of that community engagement piece, but also that program design piece. And then we have our health equity policy analyst who works with us currently, who actively assesses, again, programs, policies, and working and coming alongside all of our different program leads to help support and integrate equity throughout what they do. So it's not just kind of a buzzword, but to make it something that's a little more tangible. A key part of this work collectively is that we are also, I think Rachel mentioned this, that we're in an environment where people aren't as interested in issues of social equity and racial equity as they were before. And we also have to work relatively stealthily because we want to make sure that the work gets done regardless of how it's stated. So it makes us even more keen about how we can be creative in tackling these things across the agency. The last couple of buckets I'll share is that on the left-hand side, we do collaborate with WISE Indiana, which is our research and evidence entity within the state, within FSSA. And so we work with them to kind of learn, grow from a research, data, and evaluation perspective. And then on the right-hand side, some of our partners in community engagement who are actively working with constituents and working with community partners to move this work forward. So our office, again, went from a really tiny to not just growing in staff, but growing in collaborations just within the state, much less outside of our agency. So appreciate the collaboration with the DMHA to help us get to this point as well. And we're excited to see what the rest of this year holds. Next slide, please. So before turning it back to Sunny, I did want to just put a plug of how you might want to engage. First, if you're working on health equity, please let us know. We know that a lot of our colleagues in DMHA are probably working with you already, so we're happy to just be at the table, learn more, and support, especially from an agency perspective. And because so many of the folks that you're serving, your clients, your team, that they often need many other services that our agency provides. So we're aware that mental health and substance use is just one piece of the puzzle. If there's anything else in that space that we might need to be aware of or that we can support as an agency, keep us posted. We want to make sure that we can increase our capacity and your capacity to coordinate and convene on different topics in this space. And just really relying on your own areas of expertise. You all bring so much to the table with your own knowledge, not just within equity and cultural and linguistic competency, but as mental health professionals and substance use professionals who understand how this works for the population you serve. If you have any thoughts, concerns, this is our email address at the bottom if you want to collaborate or talk more and learn more about what we do. And then also, as we build out our community outreach and feedback arm, we will definitely be collaborating with DMHA to understand how we can support their existing partnerships and better integrate those perspectives into our work as an agency. So with that, I'll turn it back over to Sunny, and thanks again for the opportunity to share with this group.
Dr. Merritt, thank you so much. And to all the brilliant remarks from the leadership, I'd like to invite Dr. Carey and also Rachel to come back on screen. And we've got some great questions from our participants. Wonderful. So our first question is, speaking from your experience, is what Rachel identified as a great opportunity to really collaborate and better connect as staff. What are some ways we can do that physically or tactically within our provider space?
I'll be happy to jump in here. Sunny, would you mind, cut out for just a second, would you mind reading the full question one more time?
Yes, absolutely. So Rachel mentioned speak from your experience as one of the ways to really connect with staff. What are some ways we can tactically do that within the provider space?
So I think there's a lot of ways that we could answer this question. The first couple of things, and I would love for Dr. Carey or Dr. Merritt to come in and fill in anything that I miss. But so when I mention speaking from your experience, I mean both in terms of situations that have impacted me as a person and an individual, and in terms of whatever intersections of my identity may, at times be marginalized or dismissed or used in a manner that might be harmful to me as a person, as well as working to be a voice for the experiences that I have been witness to for the people that I'm serving. Some examples of that may be, as an example, at DMHA, we recently revamped the way that we assign service providers to our Recovery Works population. And so if anybody's not familiar, Recovery Works is a funding source that serves people who have been involved in the criminal justice system. As you know, in the criminal justice system in our state and across our country, we have an incredibly disproportionate amount of African American individuals that are incarcerated compared to our general population. And what we found in Indiana is within Recovery Works that despite our incarcerated criminal justice involved population being predominantly Black and Brown, that 70% of people that were being referred for treatment services were Caucasian. And so what we found was almost the inverse of the criminal justice population was who was being served through these kind of second chance opportunities and things like that. And so that showed a real demonstration of perhaps many things, maybe implicit bias, maybe some disparities in how we were referring folks, who makes it to even have an opportunity to get treatment rather than being incarcerated. And so at that time, we looked at that data and then we changed to a centralized access point and with a team that we could work with on cultural competency training and how to combat implicit bias in terms of how and who we are making referrals for. So I guess that's a really long way to say, make sure you're looking at your data, make sure that if you feel like you're observing something, you dig into it a little bit more and that you're bringing it up. Because a lot of times things that we just have accepted as status quo are really, really problematic. And using personal examples from Rachel, the person, is wonderful, as well as observations about, gosh, here's some disparities in what I'm seeing within my own organization. How might we make it better?
Thank you so much, Rachel. Dr. Curie, Dr. Merritt, additional thoughts about how providers could work with staff to provide specific, speak from your experience, examples, and or staff engagement?
You know, my mind went to some of the work that, you know, Dr. Merritt has been heading up with OHO, and this may not be the exact kind of angle that Rachel was coming from, but we've started to develop some opportunities for staff through organized initiatives like employee resource groups, or maybe more informal opportunities for staff to, you know, to relate or to have conversations. I think something like that starts from the top. It needs to be, I think, supported from a leadership framework, where leaders sort of promote this idea that it's okay to create the space, protected space to have conversations, or to sort of train around, or have conversations around some of the key areas of either equity or lived experience that kind of affect not just service populations, but the providers who are involved. And so I think any freedom or any flexibility that exists to create or promote spaces for folks to have conversations about the work that they're doing, or about ways to sort of improve, cultural competence as providers, I think is warranted. And but I can't stress enough like how much that has to, I think, be modeled and come from the top.
Yeah, I don't have too much else to add. I think Rachel and Dr. Curie were spot on. I would also add, just to make sure that folks don't feel like too tokenized in their experiences. So I think sometimes we do like to rely on, we meaning like the objective A person, might rely on, a person with a particular experience in a way that can be inappropriate. So I think it's always important to meet folks where they are. Some folks aren't ready to kind of lead the charge for a certain community just because they belong to one. And so it's important to create spaces, I think, like Dr. Curie said, where there's kind of a strength in numbers support, so that, folks feel a little more able to communicate those things, that they're able to also direct people to educational resources, or encourage people to look up and do their own research in different ways, so that it doesn't rely on like a person or an expert or the DEI person to kind of be the only one who's doing that work. So I think it's just the constant self-education piece is really critical. And I think, as Rachel said, the cultural humility piece too, to recognize kind of the when and where you can engage, so that you're also creating a safer space for your staff to feel like they can be more authentic to who they are, and maybe be a resource or be able to help support in other ways.
Thank you so much. Oftentimes we really err on what our policies say. So for example, appropriate self-disclosure might be very limiting towards being able to come together and speak from your experience. And we err on the side of being very cautious rather than being innovative. And so wanting to make sure that we have the opportunity to look at it from a couple of different perspectives on behalf of what Rachel shared on the patient advocacy side, and what Dr. Curie shared on the employee engagement side, and then what Dr. Merritt identified as far as really looking at additional stakeholders from the community outreach, and just making sure that there is collaboration and allyship and echoing what others are wanting to bring forth, and being supportive in those inclusive spaces. Our next question is specific to the slide regarding co-design. Who are, or specifically co-design, who, I'm going to edit this question a little bit just to make it more clear. Essentially, the question is, who are the voices that we need to include that are being under-included?
Yep. So I think that was referring to some of our work that we're pursuing in OHO. So I think it's about bringing patient voice or client voice or constituent voice or whoever you're serving. I think as an agency that has a terrible rap because people don't like us because we cut off their benefits, it's not that those concerns aren't valid, but I think there's both an opportunity and for us to listen, to learn, and be a little more humble instead of just saying, well, here's how the policy works and here's what it is, and kind of blaming it on that, and really kind of figuring out, well, what are the things that we actually do have control over? As a state agency in particular, we're in a position where we often have to implement things that are given to us, but there are some places where we can, make some strides. I think Rachel and Dr. Carey gave some great examples in DMHA about, hey, let's look at these standards across CMHCs and help understand where those gaps are. Let's try and figure out how to reach out to our providers. And there are things like that where we know we can, reach out, tweak some things to be of better service to folks. I'll also add that when it comes to the actual co-design process, that it's not just about, like I said, bringing constituents to the table, but really having a responsibility to give them something back. So I think often when we do these types of efforts, it's, yeah, we want to hear what you're going through, but not necessarily communicating back with you. Like, that's the co-design part. It's the communication. It's the we are peers, that we value your expertise, just like if you had a PhD too, instead of just like taking that and moving ahead. So I think really the collaborative effort comes with the consistent and intentional communication, as well as consistent and intentional efforts to try and adapt policies and programs to that. So not just about like who should be there, should definitely be the people who are receiving these services, but there's a question of like how we're working with them once they're actually here. So I hope that answers that question.
Thank you so much, Dr. Merritt. Dr. Carey, Rachel, any additional insights to add?
I just, as Dr. Merritt was speaking, the one thing that kind of popped out for me was just wanting to kind of highlight, I think, the intentionality within DMHA to make sure that our internal staff are trained, or either many are former providers or therapists or clinicians, or have training in social work, mental health, and just behavioral health altogether. And so just something that Dr. Merritt said that kind of stuck out was not just that we take into account the folks with lived experiences and collaborate in that way, but I don't want it to be lost that those who are kind of making the decisions from the state level often have experience and perspective, and I think there's intentionality in bringing folks on who have those experience and perspectives, so that we're kind of from afar right there in it with you all.
And I think the only thing I would add was just to kind of expand a little on what Dr. Merritt mentioned around the idea of avoiding tokenism. And so often, I think in positions that we create and in listening sessions that we have and the way that we get feedback, it can be, that we go through the motions of providing a platform for a person to hold a position or to speak in a forum, or any of these sorts of things, and people can absolutely tell if we are doing those things to check a box versus because we really, really want to intentionally listen and hear and understand and make changes that will positively impact the voices or perspectives that are being represented. And so I would say the first thing is ensure that you have some sort of mechanism for reciprocal feedback, both from your team members and the people that you're serving. And then two, ensure that from the front end that you have buy-in and a plan for what you will be doing to lean into whatever it is that you are hearing about and learning about. And that, and as Dr. Merritt mentioned already, that if you do hire a person that is, a director of equity of some sort, that it doesn't then become everybody else kind of washes their hands of equity stuff because we have one person here who's the expert. That is a step in a very important direction, but we all still have the ownership on us to be well-versed, be well-educated, and be able to talk about and advocate in regards to these issues.
And I was just going to add to what Rachel said in terms of bringing people in. Pay people if you can do that. You know, you would pay a consultant or a vendor or someone else. You also need to pay folks if they're coming in and providing, you know, their perspectives or their policy recommendations. If there's a way to do that, also recommend.
Thank you for the great insights this morning. Just an incredible alignment of strategies across FSSA and DMHA, and sharing that with our participants that are on our first session today. Any additional insights or takeaways that you would like to share with the provider group before we transition to our break and then to our primer with Dr. Dennis Rudnick on keys to individual accountability?
I'd just like to give a final thank you to everybody who's on the conference for all the work that you're doing.
The last thing I would say is take notes, and I would just challenge everyone that you know, throughout the next couple of days to maybe have a somewhere in your notebook a column for something I learned that I didn't know before, something that was reinforced for me, and then something I'm committing to doing differently moving forward. I think you have to be an active participant in trainings like this to really take time to reflect and think about how we might come together to make unified change, and then also to be thinking about how do we stay motivated, and by we I mean thinking about yourself individually, that when there are moments of pushback, when there are moments that you feel worried about advocating or speaking up, when those moments happen, how do you ensure that you have the support that you need to be able to push through to continue to do what is good and right? Because there isn't a single person that has been doing any sort of work in the equity space that hasn't had that experience. But it is very, very important that we keep moving, we keep pushing forward, and we don't quit when things get difficult. And I think that is as you're working through everything today, and it is very powerful. This is the therapist in me, to write these things down. Post it somewhere. I always encourage people to, after they go through impactful training series like this, write yourself a letter to yourself, addressed to yourself 6 months from now, and say, Rachel, here's where I am today. Here are the things that I hope to be doing differently in 6 months, and here's what I hope the impact is. And put a little reminder on your calendar to open that up 6 months from now and see where you are and how it's going. I think the more that we can do to have mutual accountability and to grow partnerships and connect with people that have similar investment in this space, the better we will be as a society and as a community.
Thank you again to our leadership and to all of the attendees. Just a couple of housekeeping notes. We are going to move into our networking break session. So on the top of your emailed agenda is a link to access the networking cafe. We already have multiple providers in there doing intros and welcomes. So this is a great virtual opportunity for you to network with your peers online. And then we also have additional supplementary educational videos from TED Talks from many of our speakers that will be speaking later on today on individual accountability and tomorrow on organizational adaptability. Thank you again to Dr. Merritt, Dr. Carey, and Rachel for your excellent remarks and information and these great initiatives that are moving forward. Thank you all. We will close this session now and move towards our networking cafe.